Hello, everyone. Thanks so much for joining us for our second AI Med Champions Connect meeting of 2021. My name's Alexis May. I'm Director of Content for AI Med. Just a couple of quick housekeeping points before we get started. This meeting is taking place from 11 till 1 Eastern Time today. Let me show you. There we go. We will open with a keynote panel session before breaking out into two roundtable discussion groups. You'll find more information about these on the Roundtables tab on the left-hand side of your screen. The meeting will then culminate in an open forum session back here on the main stage. Please refer to the agenda for further information, which should be visible towards the bottom of your screen. Now, before we go into that session, as you hopefully know, AI Med is the only clinician-led movement dedicated to AI in health and care, connecting educated clinicians, healthcare executives, and industry to inspire action and drive forward the deployment of artificial intelligence. And we've developed the AI Med Champions Connect platform to facilitate communication and collaboration between the key stakeholders involved in the implementation of AI in healthcare. We've already got well over 100 clinicians, data scientists, and healthcare executives within the ecosystem, with established groups including Oncology, which we'll talk about today, radiology, and many more. The platform's been designed for you to help accelerate the deployment of AI in medicine and healthcare. So if you're not already a member, the simplest way to sign up for this is to search for AI Med on your app store. The Connect community meets quarterly, tackling a different topic each time. We also conduct a small research project on the same topic. So before we get into today's discussion around oncology, I wanted to briefly summarize the findings of our most recent research project, which sought to examine applications of AI in population health. You can find the full report on our website, ai-med.io. So we were aiming to build a picture of the extent to which AI is being deployed at a population level within healthcare organizations and systems globally, to understand the areas in which AI can impact population health most successfully, and establish whether AI is seen as complementary to or as a replacement for other analytics being leveraged to inform population health strategies. We also asked about the future of population health, including the ability of AI to help address inequity driven by socioeconomic gaps and barriers. As I said, you can download the full report from our website, but to summarize the findings briefly, in terms of adoption, we found a majority of respondents were actively working on AI at population health level. Indeed, 31% had already deployed AI solutions in this space, with 19% currently evaluating performance. Cardiovascular disease, behavioral and mental health, and cancer are the top three areas in which respondents felt AI can impact population health most successfully, and we'll come onto the latter shortly, of course. The overwhelming majority of participants considered AI to be complementary to other analytics being leveraged to inform population health strategies. I do wonder whether this will evolve over time, though. And finally, a majority believe that AI has the ability to help address inequity driven by socioeconomic gaps and barriers. Just to dig into that question around inequity a little bit, it's a big theme for everybody currently, and absolutely should be. There are a couple of thoughts from our respondents. Now, while a majority of respondents agreed that AI has the ability to help address inequity, there's clearly a great deal of work required in order to grasp this opportunity. So some of the key considerations include just the sheer scale of the socioeconomic barriers involved, versus the relative infancy of health AI. The risk that AI could also worsen socioeconomic gaps if biases are not addressed. For example, it might amplify biases that are systemic if not accounted for. And of course, it all depends on the accuracy of data collection or the system it is extracted from. So how well we can recognize bias and train and test algorithms accordingly will be critical. Finally, from me, as we look into the future, here are some of the top 5 considerations from the research. And to think about those top 2 in terms of deployment and implementation, critical consideration is given to I think in making this work is about adoption of AI algorithms as a next step, with a consensus being to start with simple solutions, and after these are proven successful, to go for more complex integrated options. And of course, the great need to retain emphasis on the ethical implementation of AI. And of course, data also remains high on the agenda, including the need for transparent and accurate data as a key foundation prior to deploying AI, standardization of data collection across health systems to build integrated data sets, ultimately moving, I guess, towards a unified national or even international database. So that was a kind of very quick run through from me. As I said, you can find that report on our website. Thanks to Javion and Zebra and Medical Vision and everyone who was involved in putting that together. With that, I'm going to move on to our keynote panel for today, which will focus on harnessing the potential of AI to transform cancer care. So I'm going to invite our esteemed panel to turn on their cameras. There we go. How we're going to run this right now is I will ask each person to briefly introduce themselves before sharing their thoughts for around 3 minutes. Once everyone has done that, we'll open up for discussion. Please do feel free to post questions in the chat and we'll get through as many of those as we can during the conversation. So let's get going. Liana, let's start with you, please. Please introduce yourself and give us your 3 minutes on AI and cancer care.
Sure. Thank you, Alexis, and thanks to everyone for participating today. I'm Liana Romero. I'm the head of global marketing for clinical decision solutions at Siemens Healthineers. And I would say that undoubtedly we're at a point where we are continuously seeing the significant transformation in healthcare that has been brought on by artificial intelligence. I think particularly in cancer care, the implications are considerable and the potential is really limitless at this point. So as an example, if we take the diseases that have a significant impact on population health and which are highly prevalent in socioeconomically depressed locations and populations, these including lung, breast, prostate, and colon cancer, AI can really play a role to improve each step of the clinical pathway. So everything from enabling and increasing screening, these AI algorithms can potentially work with geomapping tools to have early identification capabilities in these high-risk members of the population so that we're able to drive them to early screening, which will make obviously a huge difference in survival rates and outcomes. And as we move through that clinical pathway of these various cancers, we think about diagnosis and AI-powered radiology image interpretation solutions that can really improve the accuracy and speed of diagnosis, identifying the smallest lesions, for example, in lung cancer, so that they can be monitored and further analyzed throughout the course and potentially prevent advancement of the disease. So these individuals, particularly those that are identified early on, unfortunately, as is the case with a lot of the lung cancer patients, will now need to be treated. And these patients obviously can benefit from the use of AI to guide that therapy decision based not just on the clinical presentation and genomic profile of the cancer, but also incorporating the personal preferences of the individual, which I think is a big key differentiator that AI technology can certainly bring. But I think for me, and perhaps most fascinating from where I see it, through the eyes of Siemens Healthineers, is in moving towards what is the application of AI in simulation of outcomes, where the recommended treatment can be applied to a digital twin to simulate the treatment efficacy. The digital twin accounts for the cancer's genome sequencing or can account for the physiology of the patient if we're looking at cases where advanced therapies are required. So consequently, adjustment to the treatment can be made in a simulated environment before the patient is ever actually treated, and thus can be customized or adapted to ensure that the patient is receiving personalized and precise treatment. So this in turn could improve outcomes as well as reduce the cost of care. And lastly, we can consider how the combination of these AI-enabled steps along the care pathway can also have a significant role in reducing disparities of care, not just by making the care more targeted and affordable, but also by factoring in the socioeconomic conditions of the patient, which oftentimes prevent not only the access to care, but can also have a significant implication on the patient's ability to continue care because of lack of resources, including transportation or infrastructure to help them get through the treatment process. So, certainly I would say that indeed we're in amazing times in the application of AI to transform cancer.
Thanks, Liana, for a comprehensive overview there. Definitely got a couple of questions around that, but what we'll do is go around the panel, let everyone introduce themselves, and we'll come back for discussion. So, Ajit, can I come to you? I'll ask you to introduce yourself and similarly give us 3 minutes on your kind of thoughts in this space, please.
Great, thanks, Alexis, and thank you for having me. And it's great to hear what Liana had to say, because I think I echo in some of the very same thoughts. But anyway, my name is Ajit Gajra, and I'm a medical oncologist, hematologist. I practiced for over 17 years in a busy clinical setting, and actually continue to do so on a tiny basis anymore, because now I work for Cardinal Health for the last 2 years, where I serve as a Chief Medical Officer for the Cardinal Health Specialty Solutions Division. So I often think of AI in terms of how can AI help the oncologist and the patient and the caregivers really in the clinic. So what are the unmet needs within the clinic, or where is it that we can actually do better? So in my mind, I break down the patient journey, and the problem with being an oncologist is that you always start post-screening. Liana, you mentioned very appropriately the importance and the way to leverage AI in identifying, screening and maybe communities or populations that are under-screened. But anyway, let's start that unfortunately the patient has now been diagnosed with cancer. And so I feel like AI has distinct applications in the diagnostic part. So there's the radiology part and the pathology part. And as we're seeing already, there's a lot of movement in those areas where AI enabled, AI powered, AI backed tools or algorithms are doing better than just clinician based, basically AI plus radiologist is better than a radiologist alone, and perhaps AI in some instances with pathologists is better than pathologists alone. So that's one bucket. The second bucket where I see AI being utilized is, of course, matching the right treatment to the patient. And this, I mean, just at the level of the tumor characteristics. So, for longest time, we've relied on just histology and a TNM staging to come up with treatment paradigms. But of course, now with the precision oncology, precision medicine revolution, I should say, there are so many options. Where we need to identify every single mutation, but then also know how to match the right drug, which in many instances, while may not be technically, labeled for that indication and such. So we're really moving from histology to a genetic mutation or genomic basis of treatment. And so this doesn't stop just at the tumor characteristics, but also the individual characteristics of, whatever germline mutation or whatever underlying risks that they may be carrying. So I feel that is the second bucket. So diagnostics, and then identifying the right treatment to the right patient, where the decision making is so complex that AI support would be appropriate. And I know that there's movement in that direction already. But the third and the most granular, I feel, and often not perhaps talked about enough, is that support that oncologists, patients, and caregivers and oncology teams need in the clinic. How do you know that someone is going to deteriorate? Cancer, unfortunately, is a very dynamic process. And 1 week the patient's doing fine, and then the next week they're just not looking good. And what happened? You can't oftentimes put your finger on it. The other tragedy is that oncologists are very focused on their training is excellent, but they only they view everything in terms of the tumor. Okay, well, I know the TNM stage, I know the biomarkers, And then I know the patient performance status. So really that should be good enough. And I have access to the basic labs. Now their EHRs are filled with reams and reams of information on the patient about where they live, what zip code they come from, and all such things. But are they really integrated into their decision making, or identifying events which lead to or may be leading to clinical deterioration? So really the point that I'm trying to make is that there's so much beyond the clinical factors, because you can have a patient, same age, same gender, same TNM staging, same tumor histology, but the outcomes might be different. There have been elegant studies where zip code impacts, but that's just one part of the picture. So, there's what oncology or cancer care has been doing is dabbling with these individual factors, whereas what we need is a comprehensive view of all of these so-called social determinants, if we will, that impact outcomes. And to be able to integrate that into clinical decision making, I think will be critical and ultimately lead to, can impact outcomes at the patient level on a day-to-day basis. So that's the one aspect that really excites me about AI and how it's being utilized. And hopefully we'll get to talk some more about it.
Thanks, Hachi. That was great. Absolutely. Again, my head's filled with questions, but I'm going to go straight to John. Let's get your 3 minutes, John. We'll hear from Mike, and then we can have a conversation, which I feel is going to be really fascinating. John.
Excellent. Thank you. And thank you for not saving me till last. It's hard enough following Liana and Ajit, so I don't know what I would do if I was fourth, but I'm John Kroenfelter. I'm an internist, trained in the 90s, so I'm starting to feel old in terms of medicine, but I'm the chief medical officer with Javion. Been with Javion for the last 5 years, but before that, I was always on the provider side of healthcare and very interested in care transformation, healthcare delivery, and analytics. 7-8 years ago was considered powerful if we could just do risk stratification. In other words, predict what's going to happen next. And that's predictive analytics, but that's now run its life cycle, I believe. And there's a shift, and I think it's somewhat intentional, and also just people realizing subconsciously it's not enough. So AI is going to help enable that shift away from predictive analytics to a space that I would refer to as prescriptive analytics. In other words, providing wisdom as to what to do next. That's one of the shifts that I see. And Liana touched on this, all the points along a clinical pathway. What should I do next is one of the main questions. And instead of it being now a pathway where I'm going to follow this path for this patient, we're going to move, I believe, with the power of artificial intelligence into a concept of a broad definition of precision medicine. Now, I've watched that term be used over the last 3 to 4 years, and mostly by oncology. It's fairly narrowly defined in terms of precision around genomics, and based upon the genomic enzymes that a person has produced by their liver, or if it's genomics around tumor markers, then precision medicine says this is the right drug. But I would say a holistic definition of precision medicine takes into account the socioeconomic factors, the environmental factors, the clinical context of the patient, and the genomic. And when you have those four together, there's nothing outside of artificial intelligence that will combine those vast amounts of data from various and disparate sources and tie it together to say, what is the next best thing to do for this patient? And that will transform medicine in general, and oncology in particular. But it's still, I think, a series of steps. I always see that this is coming imminently, but I have to be realistic. It's not this year. We're starting to see tastes and glimmers of it, but it's going to evolve, I think, over the next several years. So I borrowed from Liana. From what Ajit said, the thing that I want to highlight a little bit more is the way I see it is we have a shift from providing, again, pathway care and a plan of care to a newer definition of preventative care. What's going to happen to this patient if we do nothing or the usual things that is preventable? What can I do differently for this patient that I didn't even realize or see that I could do? And artificial intelligence is going to highlight the invisible around patients. It's going to highlight the patient who, the end of the story is there was health inequity. Something happened that was avoidable because they had socioeconomic factors pressing on them that they didn't take into account. They didn't realize. The healthcare system and delivery side didn't realize, and it just happened. That's preventable, but it's going to, again, take the power of artificial intelligence to highlight invisible risks and to surface them in time to do something differently for the patient. And this is, as I think we all feel, an exciting time in healthcare. That's my 3 minutes, Alexis.
Great, John. Thank you. I was just struggling with the unmute button. Again, excellent. Loads of themes coming out of these short talks. Let's go to Mike. You've already been set up by John as having the hardest job to do in this segment. So yeah, let's go and do it, Mike.
Absolutely. Yeah. Thanks, John. So I'll lead off by saying that, well, first of all, my name is Mike Callahan. I'm with Zebra Medical Vision. I'm our U.S. Director of Value-Based Care. And similar to Alexis, I'm not a clinician. I'm not a data scientist, but I have been working with health systems across the country for more than 20 years to solve the problems that they have, and most recently all around technology. And here with Zebra Medical Vision, we are one of the industry leaders in AI when it comes to medical imaging. And what I love about the kind of the group that we put together and the topics here is it's a perfect flow from population health to cancer care. And how do we bridge those gaps? What are the goals in population health? It's, how do we get those patients into care pathways that are going to lead to better outcomes? At the end of the day, that's what we're looking for. And so how can we tie all those things together, and how can AI, particularly in my case in medical imaging, how can we grow with the times and deliver the types of things that we need to do? And so something that Liana mentioned through, I think, social determinants and Ajit and also John, you all kind of mentioned, how do we identify the patients? How do we bring them into that care pathway? And very much in imaging AI, there's a tradition around triage solutions, or solutions that are designed to speed up radiologist workflow or identify more urgent acute cases faster and bubble them up to the top of the list in the radiology workflow. And really, from a population health standpoint, what we're working on is how do we sort of cast a broader net, and how do we capture unknown patients that may not have been identified by particular risk factors. If you're going to screen someone for lung cancer, the first question you ask is, are you a smoker, right? And there are several others, but all those risk factors go into determining, should we do this particular screening imaging study? Same thing with a mammogram, women over 40. And so that's what we're striving to do. How do we take that next step? And really it's through opportunistic screening. And I think that plays very well into cancer care, because what we're looking at doing is analyzing images that were ordered for some totally different purpose. So someone comes into the ER with trauma, they end up having a chest CT. What are the opportunistic findings that are typically overlooked by those radiologists? And how do we write algorithms to find those, particularly when it comes around cancer care? What are the early indicators? And that's what we're looking to do here is collaborate with clinicians and others and find the best path forward.
Excellent. Thanks, Mike. And thanks, everybody. Some really strong thoughts there. And I'm gratified that, the conversation around population health has informed some of the discussion here as well. I just say, Liana, just to briefly come back to your thoughts, the kind of the whole concept of digital twin, and I realised that's a reality in many areas, and I know Siemens are kind of leader in terms of digital twin technology and industry and things like that. But the tantalizing prospect of being able to make those adjustments to treatments in a digital context before actually treating the patient and the opportunity to improve outcomes and reduce the cost of care. Where are we actually at with that? Is that something that we can do now? Is it, are people actually utilizing that now? I've spoken to a few people across the world who are working on it, but give us a little bit more, about where things are at with digital twin, if you would, please.
Sure. Yeah. So I mean, definitely in the space of when we look at like cardiology, for example, that's something where it's already happening, where you're looking at, do you have to do ablation? How is that ablation? How's that patient going to respond to an ablation? Same thing with cancer, where there's lobectomy that needs to be performed. How extensive does that procedure have to be? Can you minimize the tissue damage or tissue extraction so that there's actually better recovery for the patient without putting the patient at risk that there could be a significant recurrence of cancer, for example, in a X period of time. So these are all of the different areas where we're definitely already working on, but where the potential is definitely much broader as we think about, again, let's take the case of lung cancer, where you have a teeny tiny nodule, and ideally, if you're able to monitor that nodule over time to ensure that it's not growing, et cetera, that is certainly an option. But there could be a preference in the case of the patient that says, I prefer to have that extracted. So what would be the implication of having these minimally invasive simulations to see what's that impact going to be on that patient? So it's already in progress. There's so much more potential to develop that, but it's definitely for sure cardiology and in oncology that we're seeing. And ultimately, I think where we're really going to see a tremendous impact will be in neurological situations, which is so much more intricate.
Okay, thanks so much for expanding on that. Jeet, I'll just come to you, and thanks so much. I think I really like the way that you kind of summed up those kind of three buckets where you see the sort of impact here. I guess to dig into that a little bit more, if you could identify one area where you see value being added by AI, right now in oncology care, or as soon as possible, where do you see it within those kind of areas that you described? What's the sort of most immediate opportunity?
Right. So, Alexis, I feel as though the diagnostic area or the screening area is, of course, it feeds into oncology, but it's not directly oncology. It's not. It sort of, in a way, precedes before the diagnosis, if you will. So my favorite part is the one that happens afterwards. That is that other bucket of identifying the right medication to the right sort of mutation, let's just say, or based on the genomic profile. But also, I feel that that fourth area that I was talking about, where how can the patient now has cancer, and you are giving them the best available treatment, but then what else can you do to improve their outcomes, to sort of modify their trajectory, if you will? And the other thing, it really sort of dovetails into this whole evolving concept, right? I mean, we're going in oncology and certainly across medicine from this whole fee-for-service to more value-based care. And really, what is value? I mean, value-based care is you're improving outcomes, but at the best cost possible. That's what value-based care is in its simplest form. So I think then it becomes critical to identify how do you dispense value-based care? It is to minimize, low-value interventions and to maximize high-value interventions. So, really, how is it that AI can assist an oncology practice to achieve more high-value interventions? For that, we have to identify what are the low-value interventions. So, patients get admitted to the hospital. Patients, unfortunately, with advanced cancer that you cannot do much more for. So rather than throwing one more expensive drug that's not going to work for them, if you can identify, if you can modify their course, to an area where they get appropriate palliative care, supportive care, because that's what's right for them. That's an area. So oncologists are notorious for not being able to identify when that turn has occurred in the patient's unfortunate journey, when that unfortunate turn has occurred. Patients landing up in the ER repeatedly, again, for things many a time which are unfixable. But also sometimes for things which are fixable, but weren't recognized. So can AI really help us identify, those impending problems that are going to arise, or high likelihood for, John Kroenfelter mentioned risk stratification. So, it's the next level of risk stratification, really. And again, I certainly have to admit, my work with Javion, I think that is certainly something that we're looking at. And, so to me, that is my favorite area, to be able to impact the patient journey and the patient outcome at the same time, saving the patient futile and often sometimes dangerous interventions, and also sparing the healthcare system, the impact of those interventions, which ultimately are not going to benefit the patient. So to be able to identify at-risk patients and modify their course is, I think, to me, the most exciting utilization of AI at the moment in the clinic.
Thanks, Ajit. That sounds like a pretty good description of value to me. John, to take that point further, you're in a position where you're a physician, but you're kind of at the coalface in terms of actually implementing AI in healthcare. So, for oncologists who are looking to integrate AI into their practice, that it comes back to value and how that's perceived. Kind of where do you go with those sorts of conversations? How does that work on your side of things?
Well, what we see is, how do I say this gently? In healthcare, there are incentives for physicians and providers to continue doing as much as possible, because that's how the reimbursement is set up. I am paid for activity. We're in a shift in healthcare, and it started 8-9 years ago. We're in a shift in healthcare to this concept of fee for value that will align incentives better around delivering value, better quality outcomes at lower costs. When we talk to an oncology practice, and that is important to them, delivering value and not just continuing to deliver services, what we have then is a very rich conversation, because now they have different problems that they're trying to solve, and the usual approaches and even processes don't always work to solve those problems. I'm going to give you an example. Depression is common in oncology. And so depression screening is a normal step in a normal process to identify patients at risk for depression and then to treat them. With the insights that we've provided, we into very high performing oncology practices where this is important to them, they've identified additional patients that were at risk for depression that the screens don't pick up. They dig deeper and they invest more resources there. To Ajit's point, where do I invest more resource and effort in order to do the right thing and to get value out? Is spending more time on that patient that's a risk for depression that the screen didn't pick up. And we've increased, with the insights that have been actioned on, increased depression diagnosis and treatment by over 30% over baseline in high performing practices, because the incentives were aligned and because they actioned on the insights. Now, so where do they start? They start with, there needs to be aligned incentives. I am trying, as an oncology practice, I'm trying to do something that's bringing value to the whole picture, higher quality care at lower cost. Secondly, I've got a challenge or a problem that I'm trying to solve. And with that as a starting point, I'm trying to solve that problem to deliver value. Now there's a place for artificial intelligence. There's a place for, I'll just call it intelligence. There's a place for insights that go beyond process improvement. And that's a starting place.
That's great, John. Thank you. And I'll put it over to Mike as well. Just on this topic around value-based care. So from your side, from your interactions, where do you see AI's role in enabling that acceleration, that shift to value-based healthcare?
Yeah, when what John said is absolutely true. It all comes down to delivering the best outcomes at the least possible price. And there is this dichotomy of kind of where we have been in the past, where we're going to in the future, and how does that transition take place? And I was meeting with a population health executive from a major health system just a couple of weeks ago. And one thing that he said is so very true is that with population health, all boats rise with the tide. So if you're dealing with, say a capitated health plan like Medicare Advantage patients, if you're able to deliver earlier interventions, particularly if you talk about cancer here, that end up costing you less long term, there's a win because you've got a fixed reimbursement that you're working with. And at the same time, if you've got fee-for-service patients, you're able to identify people who are at risk or people who have early precursors to disease. You can get them in and you can bill for additional treatment. So from the sort of the financial view of it, you've got sort of that end of the equation being satisfied, but most importantly, all of those patients are getting the care that they need. So that's kind of where it's going. And I think when you talk about the future, all of this stuff that we talked about, which is identify the patient sooner, get them into care pathways. Maybe my algorithms might not be able to find a early disease state, but they might even be able to find a precursor or a risk factor that is a precursor to that possible disease state, which combined with other risk factors such as are you a smoker, what are some of the other social determinant factors, all those things could come together. And the thing that you mentioned in the report, which was what was it, global population health surveillance, that's something that might be around the corner, where we take all of these different types of risk factors, some generated from AI, some generated from other tools, bring them all together and be able to get a much better picture of what is that the true state of that population's health, and how do health systems, how do health plans, how does the entire healthcare system, how do we address that so that we are getting the best value for the care that we deliver, the patients as well, of course.
Great, thanks, Mike. I think as a panel, we're in a place of clear sort of consensus, which is, I guess, a good place to be. As we've got a couple of minutes before we go into the roundtable sessions, and so I'll just ask everybody as we go around for kind of 30 seconds, just your final thoughts. And Liana, I'll ask you to, just your final reflections on what's been discussed before we end this session.
Again, super exciting times for artificial intelligence, but I want to touch real quickly on the issue of prevention, because prevention fundamentally starts with education and being able to drive a behavioral change, which from a public health perspective is the most challenging that we could possibly imagine. So if we can develop an AI component to help drive prevention and drive and instill the concern of health in patients, I think we'll hit nirvana basically. So
great, thanks, Liana. And Ajit, your final 30 seconds reflections.
So I think I'll highlight something that resonated very well with me based on what John said in terms of that shift in terms of value. I'm talking in the context of oncology practices, so going from sort of fee for service to really being rewarded for imparting good care. But I could impart a very good value-based care, but is the oncologist next door rewarded more financially because they give all kinds of interventions which are not indicated. And so really, if I had the magic tool, if my AI tools were able to support me and guide me in terms of appropriate decision making, plus I was rewarded for imparting good value-based care, then that is how we bring about a shift in the mindset and drive this forward.
Thanks, Ajit. John, final thoughts?
Yeah, thanks, Alexis. We're in a time of accelerated change. So if we think about the disruption from COVID last year, that was what we would call accelerated disruption, right? It was blew up our world. But accelerated change is also very disruptive. And so as you've even heard some of the different ways that AI is being used in this panel, it's going to be 2 steps forward and 1 step back sometimes. And it's going to take some, I would say, courageous leadership to continue to see what can be and to have that vision to drive through some of the speed bumps along the way and not be discouraged. So I would call this a time of a dynamic disruption, and we have to recognize it for what it is. It's rapid change, and it's not going to be perfect. It's going to be messy. But we also see that we're realizing now some of the early value around AI.
Excellent. Mike, final word before we move on to the next segment, please.
Yeah, I would echo what John was just talking about, is that things are changing so quickly, and the way that value-based care and reimbursements is going to change the way institutions manage themselves moving forward. And they're going to have to lean on new tools to help deliver the best possible care. And I think AI is uniquely positioned for that. When it comes to cancer care, I think it's pretty well known that the earlier we can diagnose things, the faster or the better the possible outcomes. And of course, the lower cost for the care that you deliver to get those better outcomes.
Awesome. Thanks, everybody, for a really interesting discussion. It's now time to move on to our roundtable sessions, which John and Mike will be ably leading today. As I mentioned earlier, you can find more information about these on the Roundtables tab on the left-hand side of the screen. We'll be back here at 12:30 Eastern for an open forum discussion. So with that, Liana, John, Ajit, Mike, thanks for a great discussion. John, Mike, head off to your roundtables, and we'll see you back here afterwards. Thanks again, everyone. Well, welcome back everyone for the final segment of today's meeting. Excited to be joined once more by our excellent panel. So let's hear about the roundtable discussions. John, what were your main takeaways?
We talked about socioeconomic determinants of health and factors that are putting pressure on patients, and it was a far-ranging discussion. It's hard to encapsulate it, but one of the things that we recognized is that the socioeconomic factors are one, that they're extremely impactful and important, but they're also difficult to appreciate and to discern on patients. And so various things are done in order to collect that information, to understand patients better. We talked about strategies about how better to collect that data through manual effort. And then there are also, of course, AI approaches to better understanding patients holistically with socioeconomic data as well. So that the work burden on collecting that data, the signal to noise ratio, these are things that came out as we had our conversation. In terms of takeaways, I think we also highlighted in a number of different ways, but to tie it together, that there is a role for, I'll say, machine learning to understand patients holistically by comparative techniques. Leanna had mentioned before, and we talked about again a little bit, this concept of digital twins. We also talked about a comparative technique from one of the participants around real world experience in the clinics. And then there's also the data science that Javion uses around similarity clustering to understand a patient by looking like another cluster of patients. And in all of these approaches, what we're doing is closer to real-time analysis and comparative analysis of a patient to other patients to understand not only where they are today, but also where they may end up in terms of risk or an outcome that we're trying to prevent. And so the role of AI in a comparative approach, I think, was highlighted in the second half of our discussion. Those are some good takeaways from the conversation.
That's great, John. Thanks, Mike. How about yours? Give us a bit of an overview.
Yeah, thanks. We had a little discussion around kind of how I'd set things up before, the progression from triage-based imaging AI solutions towards population health, a little bit about how we've begun to make that transition and how we're utilizing that today, and how that could line up with different types of cancers. And what are the types of things that we could look for, not just evidence of a cancer stage, but possibly evidence or precursors or risk factors to cancer. And then in our follow-up discussions, it was quite a bit technical. We talked a bit about how our algorithms are trained, the data set that we have as far as how many patients and imaging studies and across the time period of medical records that we train those algorithms on before we deploy them into the wild. We also talked quite a bit about the regulatory process, how we improve those algorithms over time and what we have to go through for that. And then finally, I'm not sure if I answered it completely, but the concern about is there a risk of raising the diagnosis level to a point, and we were talking about our vertebral compression fracture algorithm, that we would have too many results going in, and to the health providers. And we talked about how we can modify our sensitivity and specificity to make sure that we're not including mild results, for example, that we're only looking at the moderate to severe indications for different types of algorithms. So it was a really interesting discussion and very technical.
Great. It sounds like you both had some wide-ranging conversations. Thank you, everyone, for your participation there. So we'll have a little bit of a chat to round out this this meeting today. And I guess I wanted to come back to the data. Actually, John, you mentioned you were talking about the socioeconomic determinants of health and maybe strategies about how to better collect the data. as we know, without data, we can't do AI. And, it comes back to, one of the things that was mentioned in the report that we did, that kind of potential to work towards, some sort of global health surveillance, or really significant national or even international databases. How feasible do the panel think that is? I guess let's talk about a national level. It's going to be kind of slightly easier to focus on that, but like, how feasible is that? Kind of where is the burden of work in terms of the data collection, so that we can actually deliver on some of these opportunities? Who's got a view on that? I can't see everybody. Anybody want to have a go at that? No, I'm going to pick on someone that can. Say, Liana, what's your take on that? Like, what's a feasible way of delivering that? Does it have to happen through manual effort?
Yeah, we talked about some of that during John's breakout, and actually we focused a little bit on perhaps missed opportunities, particularly in the populations where access to care might not be regularly available, but that there still might be issues, for example, or opportunities, like, for example, faith-based organizations, where oftentimes these are the places where people go and they feel comfortable talking about the things that are happening in their life. And so from a public health perspective, a lot of educational initiatives are focused on these faith-based organizations. So that's one example. Another one would be pharmacies. So I mean, there's different opportunities that are often missed for data gathering, but at the end, there's still obviously this component of the data collection being manual. And then how do you incorporate that manual data component into ultimately an electronic health record, where this information is now harnessed and applied in AI situations to be able to actually take a next step. So there were also some ideas of how perhaps the data can be harnessed through other sources. Maybe there's payer data that can also be tapped into. So I think we just need to think about these situations outside the box and look for all the opportunities where data resides and perhaps is not being utilized to its maximum capacity at this point.
So what's the mechanism? What's the lever to actually make something like that happen? We could do that within an organization as not a top-down sort of diktat, I guess. But how does that actually work? And interestingly, it kind of feeds into something we've been thinking about a bit recently. And actually, it was a talk that I saw by a couple of people, one of whom John Lee is CMIO at Allegheny Health. And he's been talking a lot about it's about the kind of the potential of EHRs, or the kind of missed potential, and the fact that, when we're talking about manual collection of data, we've still got a lot of data that exists that is physical. In the UK, we had a drive for the NHS to be digital, paperless by 2020. So it's 2021. I'm not 100% sure, but I'm pretty confident that we did not do that. But yeah. What happened in the drive to do that in that 10 years or so, when they said, right, okay, this is what we're going to do. So a lot of the solutions that came out were simply to take digital images of the physical documents and put them into, rather than actually take the information, the data. So that there's still lots of that, and I realized that that's a universal challenge also. So on the basis of the assumption that doing something like this would be useful, like how would the panel see that working? At an organizational level, how do we actually start to get that data in a shape systematically collected in a way that's really going to change things? John, it looks like you got some thoughts.
Yeah, I'm wrestling with this, Alexis, because yeah, I'll just speak from the experience in the United States, is that I don't see yet a safe pathway to navigate for a common data source for socioeconomic data. And that's kind of what I heard you alluding to. And I'll give you an example. To nationalize that as a data set for consumption, for benevolent purposes, it'd be great, valid distrust that it could also be used for nefarious purposes. And there are other countries using large amounts of socioeconomic data in order to not just understand, but to control their population. We have no interest in that culturally in the US. That's a risk of nationalizing it. So then you say, well, let private industry do it. And big tech is already doing it in the US for business purposes. And our data is already being sucked out of our homes from the Roomba that vacuums your house, and they sell data plans on your house in order to make money, to other big tech, understanding that when you cough, you might be more at risk for a cold, and they're going to recommend that you let them purchase cough tablets from the local CVS. It's ridiculous. So having that social data managed in large ways by big tech is no safer than if it's nationalized. So you say, well, then what's the solution? I don't see a good path to chart, like to make it holistically available for the common good without it also being for the common harm. Mm-hmm. So then you're down to local benefit, which is more costly and it's inefficient. But that's the space that we're in right now, is we take data in a proprietary way from disparate sources, and we create a holistic view of patients, but for very specific purposes in healthcare. And then providers and payers have an interest in this and understanding and seeing their patients holistically. Now, it requires, I'll just end with this, I don't want to monopolize the conversation, but it requires, first of all, good data sources, and then two things. Correctly interpreting that data to turn it into intelligence, because there is a huge set of assumptions that are wrong around data being interpreted and what we can conclude from it. And then secondly, AI will always have to fill in the blanks. To Liana's points, we have a large set of holes to fill at times around patients, and there's a risk for bias if the machine learning doesn't recognize filling in the gaps on this patient is safe, but filling the gaps over here could lead me to wrong conclusions. It's going to take AI to inform AI when to do that well and when not to do it at all. So that's where we're at. That's how I see it.
Okay, that's a well. I don't want you to come up with a solution, John. But you're right. There's a challenge there. But do we can't get to a point where a choice has to be made, or it's just going to be made for us? I mean, I guess in many ways, there's probably a kind of consumer almost acceptance that big tech is just doing this. Right, I'm not suggesting that is definitively the case, or yeah, but I think that it's fair enough to say that there's a perception. Is that is there going to be a sort of distinct choice, a point at which that's what it looks like if we're going to kind of have a sort of global effort in this way?
I'll let someone else answer.
Well, for my part, I just feel, I think we can sometimes lose our way into the fog of utopia. So I think, very simply stated, what is, we shouldn't forget, what are we using this data for? To improve outcomes. So, so it should be easy, it should be easily accessible, and it should be as complete as possible. So, the biggest problem with large volumes of data is so much of it is incomplete that you cannot draw any, consistent inferences. So better to have, if I'm I'm a payer, I'm a regional blue. I mean, and I have 1 million people in my membership. I want complete data on them. So, I mean, I feel, unfortunately, while we would like for the entire population to have to have a digitized footprint that is easily accessible or accessible to the ones that have high level security clearance and are not going to misuse it, but that's not going to happen anytime soon. But at least in segments, if it's Allegheny Health or it is whoever it is, for a chunk of the population that they're responsible for, and if we were, well, should I say that? Not a communist country, but I mean, in a different type of a government structure, a county or a town, or could do that for all of its population. But I think it has to be digitized in a way that it's mineable. That comment about the NHS just taking pictures and scanning them, and it makes me cringe, because that's the abject failure of the entire goal of sort of digitizing data and making it accessible. So and again, we started out by talking about cancer patients, so it doesn't have to just stop at the socio-demographic factors, for cancer treatment. Also, all of their tumor mutations and their BRCA status and everything has to be in fields where it can be accessed numerically or digitally. I mean, that is, I feel, this is not insurmountable. This is doable. And so I feel like, we have to start with the next generation of EHRs, or stop calling them EHRs, call them intelligent health records or something, because they have to have more capability than just being databases where things are dumped in. How are we then utilizing it? I mean, is it utilizable, or is it just a data dump and you don't know what's what? So we have to move in that direction.
Okay, I think that's those are sage words, Ajit. Thank you. So I'm going to ask our panel for any closing thoughts. I think we're going to finish up a little early. I won't have a long summary. So it's been a really interesting conversation today. I appreciate everybody's time and involvement. Let's just I'd be interested to hear from the panel, people who are involved, people who are watching this now on demand. What would you like, what would the next steps be for, people looking to do something in this space? Liana, I'll come to you first of all.
Well, I think the biggest takeaway is that obviously AI is an enabler. It's absolutely an assistant. It's something that's opening up a lot of tremendous opportunity in healthcare holistically. And so where there's still potential concerns about adoption of AI, I think we've demonstrated the benefits that AI can bring into healthcare. So I think we're at a point where now it's about how do we come together to make it happen so that it becomes mainstream and it really takes us to the next level of healthcare and really providing the best outcomes that we can for patients, particularly as it pertains to the complexity of cancer care.
Great, thank you. And John, final thoughts?
Yeah, healthcare still is very behind compared to probably every other industry in terms of leveraging the power of AI. So unfortunately, the people in the AI med community are the people passionate about it. So I guess there's two groups, but to the people in the AI med community on this webinar and others, don't settle for the status quo. Don't settle for people pushing back. Push forward with using and adopting AI in healthcare. It's time. And to healthcare more broadly, we need to be willing to change the paradigm and to learn and adopt faster change than the traditional medical establishment allows for.
Yeah, I think broad agreement there, John, and certainly, I think that articulates AI Med's perspective on this as well. We want to see change happen. It needs to happen, and we don't need to wait for it. We can push to make it happen now. Mike, are you still with us? I can't see you on my screen.
I'm here.
Oh, you are there.
Yeah. I think Liana and John hit the nail right on the head. AI is very mature in what it does. I know we've spent years building algorithms, but it's really, how do you integrate it into the healthcare environment? What are the pieces that you put around it? How do you operationalize it? How do you extract the value that the AI is able to find, or what it does to make it work in this healthcare environment? And that's where we're excited. We're certainly excited about what algorithms can we build that will find cancer indications, but we're also very excited about working with clinicians and data scientists to figure out how do we put those building blocks of the sort of the operational workflow and clinical workflow around those things that makes it valuable.
Great, thanks, Mike. Indeed, exciting times. Ajit, I'm going to give you the last word before I close up here.
Great. No, this has been great. So all that I'd say is, AI, to echo John, is sort of, unfortunately, in its, I shouldn't say infancy, but maybe toddlerhood when it comes to, healthcare overall. And I really feel as though, we need to go from simple decisions that AI is helping us currently with, cancer, no cancer, or stroke, no stroke, to more complex decisions where there are multiple factors funneled in to that complex decision making, as exemplified by various scenarios in cancer care. So I think the road has been a little long and tortuous, but I think it's a fun journey, and we need to just keep pushing forward. And I think we're making progress. And that's what we need to keep doing.
Thanks, Ajit. And yeah, agreed. And really glad to have all of you along the journey with us. That's it for today. Thanks everyone so much for joining us. Again, if you've not already done so, please do sign up to AI Med Champions Connect. Keep the conversation going within the app. Simplest way to do that is to search for AI Med on your app store. As I mentioned, alongside our quarterly meetings, we conduct a small research project, which this quarter will continue the focus on oncology. Please do feel free to get in touch with me on alexis@ai-med.io if you'd like to participate in that project. We also have a swathe of exciting events coming up, including our imaging virtual conference on the 29th and 30th of June, and primary care and population health on the 28th and 29th of September. And finally, the exciting return to live events with our all new global summit in California next January. We're already polishing our sunglasses off in anticipation of that. On that note, I'd like to take the opportunity to thank again our excellent panel for their contributions today. Liana, Ajit, John, Mike, thank you all so much. Thanks to everyone for joining. We look forward to seeing you at our next AI Med Champions Connect meeting in August.
Thank you so much.
Thank you.
Thanks
Alexis.
again.
Bye.